Okay.
Okay, perfect. Should I get started?
Yeah.
Okay, perfect. Good evening, everyone. Thank you so much for joining us today. I'm Sarah Chamseddine. I'm one of the junior immunology faculty at Boston Children's, and we have Sonia Iosim, who's one of our wonderful second-year rheumatology fellows, who's going to present a very interesting case for us today, and we're happy and excited to hear your thoughts. But first, I just wanted to throw out a quick reminder for everyone that the Journal of Human Immunity is accepting submissions, and we're very excited for how quickly this journal has been growing and with all of your contributions. So please keep doing so. And yeah, if let's just get started, maybe Sonia.
Yeah. And thanks for the introduction. Like she mentioned, I'm a second year fellow in rheumatology, and I have an interest in the overlap of rheumatology and immunology. And I consider rheumatology kind of just a subset of immunology. And I have a particular interest in HLH. So I'm excited to be speaking with you all about this case today. I'm going to share my slides. Okay. Let me know if things look clear on your end. And do you have the presenter view or the kind of correct view on your end?
Great. Yeah,
Okay.
perfect.
Okay, perfect. So I'm presenting a case on a patient I followed for a great portion of my first year of fellowship from 2024 to 2025. And his course was very atypical for all of the specialists involved. It took many months of teamwork, of escalating concern, and going back to the drawing board numerous times for us to finally arrive at a diagnosis. I have a timeline at the top to help us visually track his course over the months because it was so many months that he was in the hospital with us. But starting in August of 2024, this 14-year-old boy, originally from the Dominican Republic, presented to us with several months of fevers, night sweats, malaise, weight loss, and had a diagnosis of tuberculosis from his home country. And prior workup in the DR had revealed a positive IGRA. His chest x-ray was unremarkable, no cavitary lesions. He had a CT showing hepatosplenomegaly and retroperitoneal lymphadenopathy, and he had a superficial inguinal lymph node biopsy that was nonspecific, showing some reactive lymphadenitis. His bone marrow biopsy had no evidence of malignancy, and there in the DR, he was started on isoniazid, rifapentine for extrapulmonary TB, and this was 6 weeks prior to him presenting to RED, but he had ongoing worsening, a worsening fever curve, and then he presented to the Boston Children's Emergency Room for further evaluation. In RED, he was febrile and very fatigued appearing, but he was stable. And his labs were notable for kind of what you see here. So he was pancytopenic. He had transaminitis. His ESR was low. His CRP was somewhat elevated. He had a high LDH, a low fibrinogen. His ferritin was over 8,000. His CXCL9 was over 100,000. His soluble IL-2 receptor was over 12,000. His IL-18, not shown here, but it was not impressively elevated. And overall, as you can see from these labs, his presentation was concerning for HLH MAS. This was our initial differential for his underlying trigger. And obviously, he was on the older side for a first presentation of familial HLH, but we did, of course, consider it. First, thinking about malignancy, and his retroperitoneal lymphadenopathy was most concerning for a lymphoma, infection. So, tuberculosis, of course, that's the diagnosis he came with, but also viral infections like EBV, CMV, bacterial etiologies like Brucella. We also thought about parasitic etiologies. In terms of rheumatologic disease, he had no clear features of a primary autoimmune or inflammatory disease. For example, no symptoms concerning for systemic JAA. Castleman's could be considered with the lymphadenopathy. We also needed to consider sarcoid. And then certainly our primary immunodeficiency or immune dysregulation disorders So, lymphoproliferative disorders like XLP, CD27 deficiency, ALPS. Immunology was very involved from the start, and his functional immune and genetic workup was actually unremarkable. He was admitted off of anti-TB therapies to really start off from a clear slate. And the rheumatology, ID, oncology, and immunology teams were consulted. He had a core lymph node biopsy of a pelvic node with us, with IR, and this showed subacute necrotizing granulomatous lymphadenitis. So very consistent with TB. Of note, there were no organisms found. He was started on treatment for extrapulmonary multi-drug resistant TB at this point since he was pre-treated. And with us, he was started on rifampin, isoniazid, and linezolid. Of note, he had to be switched to ethambutol, amikacin, and moxifloxacin because he did have a lot of hepatotoxicity, especially with his transaminitis with the HLH. And then he was started on treatment for secondary, at this point, presumed secondary HLH with anakinra. And he had no response despite escalating doses of anakinra. And so eventually he was pulsed and methylpred was started around 1 mg per kg daily. Despite this, he continued to have very high spiking fevers daily. His inflammatory markers spiked, so his ferritin went up to 23,000, and he had worsening cytopenias. And this was the course throughout September. Oncology, oh, sorry, here we go. Oncology was reconsulted. So at this point, he had another bone marrow biopsy following his initial bone marrow biopsy in the DR. And this showed hemophagocytosis. So that didn't really help us. That we already knew. There was no evidence of malignancy or organisms. And his marrow was slightly hypocellular, but it didn't correlate with the severity of the peripheral cytopenias. He had a PET towards the end of September, and this showed an enlarged spleen with multiple FDG avid masses, focal uptake in an enlarged liver, and again, this lymphadenopathy in the retroperitoneum that was wrapped around basically the iliac vessels. So surgery and IR were consulted. Surgery, as you can imagine, recommended against an excisional biopsy due to the high risk and the high risk location and the high risk state of the patient. He was thrombocytopenic and coagulopathic. And so IR completed a liver biopsy in early October, and this showed non-caseating granulomas concerning for infectious versus inflammatory disease. Again, no sign of the organisms, no sign of malignancy or other etiologies. So treatment for presumed TB and secondary HLH was continued, but he was worsening. So by October, he was escalated to a JAK inhibitor, and he had a very impressive response to ruxolitinib. This is his ferritin curve. So you can see where he spiked at over 23,000 and ruxolitinib was started and he really dropped. And his clinical course, his fevers, everything improved sort of along with this ferritin curve. He even started gaining weight. And he was not previously gaining weight on steroids. So the ruxolitinib was really, really working. And his improvement lasted for about a month prior to his HLH then reflaring at the end of October. And it was unclear to us at first why he was reflaring. The resistance of the TB was always a concern, but we were actually adding antibiotics rather than de-escalating them. So you can see here we added rifampin because his LFTs had improved so much. With the help of some brainstorming with pharmacy, we realized that when he was started on rifampin here, it may have altered the metabolism of some crucial drugs like his steroids, like his ruxolitinib. And so we stopped the rifampin, we pulsed him, and we restarted him on IV steroids, and he responded to this. What was most striking to me over the course of this month was that he was responding most to the immunomodulatory therapies, and he had virtually no improvement on the antimicrobials. We knew that treating TB was going to be a slow process, but even ID was surprised at this point. And the central mantra of treating secondary HLH is that it will improve with treatment of the underlying trigger. And treating that underlying trigger is really your main goal. All to say, I was very suspicious about his TB diagnosis at this point, and I was pretty curious about his drastic response to Ruxo. And the complications in his course this month led to yet another malignancy evaluation, this time after weaning him off of steroids, since we know they can obscure cancer. Okay, so by November, he's weaned off of all steroids following this very careful steroid taper, with the goal at the end of this steroid wean to rebiopsy. However, he actually remained fever-free with improved labs, with clinical improvement. He looked great off of steroids. One question was that maybe his TB was finally responding, but also he was still on the ruxolitinib. And as we saw, he really, really liked that medication. So the repeat PET at the end of November showed actually interval improvement in multiple areas of his lymphadenopathy and decreased splenic masses. Surgery was reconsulted, and they determined that, yes, excisional biopsy of the deep nodes was still too high risk, and they were probably also wondering why we were going for a 20th biopsy of this patient that was finally improving. By this point, it was December, and he had undergone this painstaking steroid wean for malignancy reevaluation. So the goal was to biopsy something. And he underwent repeat bone marrow biopsy and liver biopsy. His bone marrow biopsy, again, unrevealing, despite still having pretty severe pancytopenia, although the rest of his labs were improving. And his liver biopsy on this specialized phyte staining showed 1 to 2 small fragments that could be contaminant versus possible fragments of acid-fast bacilli. He, around this time, reflared, and his CXCL9 peaked at, again, over 100,000, close to where he was when he first presented to us. And to avoid restarting steroids, tacrolimus was added instead. And he was discharged Christmas Eve with a diagnosis of still tuberculosis and secondary HLH, and he was discharged on ruxolitinib and tacro, along with his MDR-TB regimen of amikacin, moxifloxacin, and ethambutol. And he had a plan for ongoing surveillance. So there was a plan in place for a PET CT every 2 to 3 months, repeat ultrasounds to continue looking for accessible lymph nodes. So there was ongoing suspicion about this case and about his diagnosis. Unfortunately, as was not a surprise to many of us, he represented to the ED 2 weeks after going home. He presented with weight loss, he had electrolyte derangements, worsened hepatobiliary dysfunction, pretty severe coagulopathy, and uptrending inflammatory markers. He was admitted to the ICU, and then his daily fevers restarted. He was clearly back in active HLH. He was stabilized on emapalumab with the blessing of ID, of course. And as you can imagine, although emapalumab is such a great treatment for MAS HLH, you do not want to give it to a patient in whom you're suspecting tuberculosis. You don't want to shut off their interferon gamma. And he had a significant but very transient response to the emapalumab. And this really kind of kept things at bay while he underwent yet another repeat workup and PET, and surgery was reconsulted again. The PET at this admission in January showed significant worsening of uptake in his liver and spleen, improvement in his abdominal nodes, so those seem to have disappeared, but appearance of these new thoracic nodes, which you can see here. And through the pretty heroic efforts of one particular surgeon, the surgery team agreed to take this sick and coagulopathic thrombocytopenic patient for a thoracoscopic biopsy. He went to the OR in January of 2025, so just about a year ago, for a right paratracheal excisional lymph node biopsy via thoracoscopic approach. Surgery initially biopsied a small axillary node. They were very nervous about this patient, understandably, because that was safer. Thankfully, they did intra-op path. That biopsy really didn't contain anything. It was adipose tissue. So they went back for that goal paratracheal node and it was excised. And pathology finally on this biopsy gave us our diagnosis. And so the pathology showed a T cell histiocyte rich large B cell lymphoma, a subtype of diffuse large B cell lymphoma. And he was transferred to the onc service. He was started on HLH and lymphoma directed therapy. And he was discharged about a month later, recovering after his first cycle of chemotherapy, doing well. And to my surprise, he was actually continued on his anti-TB therapy following his lymphoma diagnosis, given he had granulomas and a positive IGRA, but we can circle back to this during the discussion section. Here's his overall timeline from August 2024 to February of 2025, just to show you and highlight the important changes in therapy, the imaging, all of his biopsies, and his diagnosis finally came at this late point in his course. As of mid 2025, I'm very happy to report that he achieved remission following several cycles of chemotherapy. And we do have our wonderful hemonc fellow here to review his oncology course and diagnosis in further detail. And I was thinking now we could sort of pause to discuss that, and then I'll kind of go back to the rest of his discussion.
Sure, great. Thanks so much for that. It's a sort of a for sure whirlwind and such an odyssey for this patient of mine and all of ours. I mean, it was a tour de force of many services in the hospital. So just like you were saying, initial treatment for this patient after we made the diagnosis of lymphoma was not our standard treatment protocol because he was too sick with his cytopenias and his liver toxicity to start our standard of care. So he was treated with a modified HLH 2004 protocol with low-dose cyclophosphamide and rituximab until his count sort of stabilized enough to treat him. Per a standard treatment protocol, the one thing that I'll mention is that the pathology initially diagnosed him as a specific type of non-Hodgkin's lymphoma, but actually our pathologist, we have had long discussions about this patient in our oncology tumor boards as well, felt like because of probably all of the therapy that this patient received prior to his diagnosis of lymphoma, he really wasn't able to make a clear call of what type of lymphoma this was. And in fact, there were some features of Hodgkin's lymphoma and some features of non-Hodgkin's lymphoma. So he really was basically only calling this B cell lymphoma. And so we sort of had big discussions with our lymphoma group about how best to treat him, but we ultimately decided to treat him sort of as a primary mediastinal B cell lymphoma with dose-suggested EPOCH-R, which is high-dose prednisone, doxorubicin, cyclophosphamide, and rituximab. So he ended up getting 6 cycles of that once his HLH was under better control and his sort of cytopenias and his coagulopathy and his transaminitis had resolved enough for him to get chemo. And he responded really, really well to that. He's been off therapy now for 6 months since June and has no evidence of any recurrent disease. So we continue to sort of trend his HLH markers and obviously all of his cell counts and everything, but he's been doing great. He's going back to playing baseball. He's in school. So yeah, he came in very sick and he was really sick in our hospital, as you can see, for a really long time. And he's made a remarkable recovery.
Thank you so much for those updates, for the kind of describing the complications in his diagnosis, and so happy to hear that he is in fact still well, going back to baseball in school. All so exciting to hear. Um, I wanted to, let's see if this is still working. Um, Kind of go into a little bit more of a discussion about his course. And it's difficult to pinpoint what could have been done differently. I think there was a lot of really great discussion and teamwork in his case, so it's really hard to say if anything could have been done differently. But I wanted to point out a few papers that were good food for thought, and then also I have some slides based on interviews and discussions with the various subspecialties that followed him. This paper from 2018, I thought offered some great insights into thinking about malignancy when working up a patient with HLH. And some of the guidance offered was concordant with our approach, although some aspects and complications of his case might have been a little unavoidable. The overall takeaway from this paper was an emphasis of the critical importance of searching for underlying malignancy and refractory HLH, and moreover, underscoring that proceeding with treatment of unclear HLH can obscure malignancy further and can be detrimental to patient outcomes. The authors here presented a series of 9 patients in whom an initial diagnosis of HLH delayed the discovery of underlying malignancy and appropriate therapy. And I pulled 2 excerpts I felt were applicable. They're a little bit on the longer side, but I wanted to present them to you here in full and just give you a moment to read them because I think they're so critical. And then I'll kind of summarize my takeaways from these 2 excerpts. So I think from my perspective, this first quote highlights the significant risk in morbidity and mortality of missed malignancy in patients being treated for HLH without full understanding of their etiology, especially like it's noted here, kind of promotion or selection of resistant clones and really transforming the neoplasm in the process of treating for HLH, which I think was probably the case, it sounds like, for this patient. And the second points out that stopping or significantly cutting down the HLH therapy is often necessary to obtain diagnostic results in these scenarios. If you're already too far down the road, HLH therapy has been started, but there is a refractory HLH, a question of malignancy, you may need to peel things back. And this was, I think, approximately the framework for our approach. And this paper reminds us that this dilemma has been encountered before. Malignancy-associated HLH is really, really hard. And this encourages us to listen to the lessons learned. So in terms of discussing the very long and difficult path to diagnosis for this patient, I think that the first step required recognizing that TB was not the driver of his presentation, that we were missing something, which was arguably the most critical step. And I wanted to discuss how each specialty thought about this. Then the second step was safely obtaining an adequate and diagnostic tissue sample, and this major barrier to diagnosis was mostly out of our control. From our perspective in rheumatology, we were keeping in open differential based on our observations of how his HLH behaved, seeing that it was not acting like the underlying process was under control with antibiotics. And ID's open communication about their uncertainty of the TB was crucial. First and foremost, the way that we think about secondary HLH, it should improve with successful treatment of the underlying process. And if it's not improving, it's a sign that we are not treating the underlying disease. Second, maybe a smaller clue, but his cytopenias were far out of proportion what we'd expect to see in HLH alone. And there was no evidence of TB infiltration of the marrow or any other process to explain the cytopenias. So we felt maybe there was another process contributing to this, especially because even when the rest of his HLH labs improved, his ferritin improved, his LFTs improved, the cytopenias really persisted. We did think about splenic sequestration. Objective evidence of this was not found though. And additionally, from my perspective, based on a literature review that I was doing throughout the time that I was taking care of him, although I have no expertise in the subject area, if anything, we have a hemonc fellow who has more expertise in this. Um, I was actually broadening my differential for his granulomas. I found some case reports that I felt could explain his full picture, including his granulomas, which to me actually provided a cohesive alternative potential diagnosis. And so these were some of the articles that I had come across. Diffuse large B-cell lymphoma with chronic granulomatous inflammation, classic Hodgkin lymphoma with marked granulomatous reaction, granuloma with an underlying lymphoma. And on discussion with our pathologist, it is a rare, but it's a known phenomenon that granulomas can be associated with lymphoma. And in this way, for me, instead of ruling out malignancy, the granulomas actually increased my concern for malignancy at some point. I think that there was no final consensus whether this was a single process or two separate processes. And of course, he finished his course of anti-TB therapy. And I don't know if our hemonc fellow has any additional thoughts about this peculiar histology.
I think that it is true that lymphomas can rarely cause granulomas, but in the vast majority of cases, those are non-caseating granulomas. And his presenting biopsy, where he did have granulomas, they were caseating granulomas, which in the setting of him having a positive TB test, I think was more consistent with that. I also think that, I think our infectious disease colleagues were very suspicious for a long time that this was TB, and I think all of us were. The problem is that a lot of times these lymphomas can be very patchy, and we can't treat a cancer if we can't find it. And the patient underwent multiple lymph node biopsies. We did a bone marrow biopsy, right? Like if we he and ultimately his final bone marrow biopsy did show involvement of lymphoma, like that by the time that we got to him in January, but his initial bone marrow biopsy when we did it when he came in was negative. So I think it was just that this is a very sneaky lymphoma, and probably the pelvic node that we did that he had biopsied in the Dominican Republic and that we re-biopsied was just not the right node, and the other nodes were very difficult to access. And even like obviously an FNA was not performed, but even a core biopsy doesn't give you an entire node, right? And so you can have very patchy involvement within a node of a lymphoma, like 10% or less. And so even just getting a core, you're missing a huge portion of the node. So was it not the right node and we couldn't access the right nodes? Was it that, by the time we repeated biopsies, he had been treated with steroids and steroids kill lymphoma? I mean, I think that everybody across the board was suspicious that this was TB driven HLH. But like I said, we won't write chemotherapy if we can't find the cancer, and that was the
Yeah.
real problem here.
Yeah, yeah, super, super helpful insight. So thank you for that. Um, and actually, one additional piece I was thinking about was this positive TB test, and I was asking ID uh, since it's an interferon gamma release assay with him being in HLH and having so much interferon gamma, could it have been a false positive? And they said that maybe, yeah, it could have been, but yeah, certainly, like you pointed out, those were some caseating granulomas from the start. These are a few of my notes based on my discussion with the infectious disease team. And so from our discussions with them, of course, TB remained a possibility throughout his course, but the way that they framed it to us, they said it remained unconfirmed. And they were really one of the teams that continually advocated for opening the differential. And we had a lot of TB experts come on board. And they said, certainly we can't rule out that this is some very resistant peculiar TB, but this doesn't necessarily make sense for TB here and now, these many months out. I think this was maybe one potential area of improvement for all of the teams because I think some came in and saw at face value he already had an infectious diagnosis. Why did we need to do more digging? But I think there were those who were a little bit more attuned to the conversations between the teams could pick up ID's doubt and concern about the diagnosis. And it was really helpful when ID started to speak up more, that they felt like we need everybody else's help. We don't think we actually know what's going on here. And then some additional complications for his course included, as we know, he was pre-treated in the DR. So sure, organisms would be more difficult to capture. They wouldn't necessarily be appearing on biopsies. And maybe he wasn't improving just because the TB was so resistant. And then also he was unable to tolerate, if you recall, his initial standard typical TB regimen because of his hepatotoxicity with the HLH. So every time he worsened or didn't improve, we had to ask ourselves, is he just not improving because we are not adequately treating the TB? I think we've had some amazing input from our oncology fellow, but basically in terms of discussion with his oncology team, what we talked about was first the suspicion for malignancy remained throughout his course. As we saw, we went back for biopsy after biopsy and weaned him off of the steroids, really spent sort of months being very thoughtful and kind of careful about his malignancy evaluation. Steroids at the beginning were avoided until deemed absolutely necessary. So he was on anakinra and we were really avoiding steroids for quite some time until we had biopsies showing no evidence of malignancy. And he was weaned off of the steroids for reevaluation. He was discharged off of steroids, and then he was discharged with this surveillance plan for pets every 2 to 3 months. And I don't know if you wanted to jump in with kind of any remaining thoughts about kind of your approach with this kind of complicated patient.
Nope, I think we covered it.
Okay, awesome. One additional thought that I had that sort of belongs, I think, more so in the oncology category, was concern about pretreatment of his lymphoma by the ruxolitinib. So certainly we took him off of the steroids. We know that the steroids were, pre-treating him, but earlier I talked about how drastic his response to the JAK inhibitor was, and his lymph nodes really shrunk on imaging while he was on this therapy, while the steroids were held. And during one of our meetings with the pathologist after the lymphoma diagnosis was made, they mentioned that they did see some evidence of JAK stat staining on the malignant cells. And so they said that yes, maybe the cancer was responding to the ruxolitinib. And it certainly would not have been probably very safe to discontinue the ruxolitinib. But I just felt like this was an interesting and important piece of information. We all thought that we'd removed all medications that could be possibly pre-treating him. We removed all medications that could be treating the cancer. He's improving, so it must not be cancer. But that one kind of medication stuck with me in my mind as we may actually still be treating his cancer. So sort of just a ongoing question that I had. And the second step of making a diagnosis and getting a good tissue sample required the help of IR and surgery. And this depended on his clinical stability and his eligibility to undergo these procedures. So this added another layer of significant difficulty to his case. Surgery had to weigh the risks of excising retroperitoneal nodes along the iliacs of this neutropenic, thrombocytopenic, coagulopathic patient. And the determination twice was that this was not going to be safe. And it was really thanks to the lucky change in location of his nodes in January that allowed for safer, although still very high risk access. We were also very lucky to have the chief of surgery working alongside us to ensure that that optimal biopsy was obtained, because he really made a lot of surgeons very, very nervous, and it was hard to get him into the OR. And in terms of pathologies considerations, I spoke to the pathologist who followed his case, who stated that in cases like his, excisional biopsy typically is best. It should be the primary approach taken in patients who have peripheral and easy to access disease. But when access is difficult, core can be enough. And in his case, it ended up not being enough. We needed that excisional node, but we were doing sort of everything that we could. We were following the standard procedures, and there was probably nothing we could have done to push harder for an excisional biopsy sooner. So I think it was really that node that moved, the collection of nodes that moved into the thorax that helped us and let us finally get that tissue sample.
Yeah, we had also pushed our amazing oncology surgeon to see if he would take his spleen out because he had this
Right.
huge spleen, and
Yes, we
told
talked.
me absolutely not. They were really worried about like even a partial splenectomy they thought would be very, very dangerous and a complete,
Yes.
so they were not really willing to risk that either.
Yes, I do remember those discussions. I think a lot of the rheumatologists, a lot of the rheumatology attendings were also, very much for getting that spleen out. But yeah, thinking about the massive size of his spleen too, and the massive open incision that would require in this patient who was barely able to clot and had platelets that were just so low for so long, it makes sense that the surgeons were very, very nervous about this patient. Um, well, I wanted to give us a little bit of time for opening the discussion and kind of digesting this case. I was so grateful to have the opportunity to take care of this amazing patient and family and to learn from him, to work with a lot of brilliant people and teams who took part in his case, and then to also share his story with you all today. Hopefully, I was able to pass along some of the important lessons that we learned and maybe suggest a framework of how to approach searching for a difficult to detect driver of HLH. But yes, I would love to open up for questions, and I'd love to hear your takeaway from this case.
Thank you so much, Sonia. That was great. A very complicated case, and I think we're just very lucky to have such strong multidisciplinary collaboration. I think obviously 5 months is a lot, but I think in the long run, it was actually not too bad for everything that was going on and all the complicating factors that were going on. I wish we had someone from ID, but Sonia, do you recall how the TB diagnosis was made at the beginning? Or because I remember there was some confusion and it wasn't like as clear
Mhm.
cut. And
Yes.
there were some questions about that in the chat about Acarius, which was negative in September.
Yes. Yes. Oh, sorry, I haven't looked at the chat. I can
It's okay, yeah, I'll sort of help out with that part.
okay.
Know that there was always that question of like, it wasn't such a clear-cut diagnosis to begin with, but
Mhm.
also very convincing features. So it was a little confusing.
Yes. So that initial diagnosis was based on a positive IgRA, um, and granulomas on that first biopsy back in the DR. And the chest x-ray was clear, so they called it basically extrapulmonary TB, or actually, sorry, at that point they called it latent TB, mistakenly, and so it started him on a lower potency course, which also was kind of a complicating factor by the time that he got here. He wasn't on an optimal course for what a patient with extrapulmonary TB should be on. But yeah, so it was really those two pieces: granulomas plus positive IgRA. I mean, it makes sense. It really did make a lot of sense.
It's just complicated because he never grew an
He
organ.
grew nothing. There was that like fight stain that I mentioned, and I
Yep.
remember them kind of like scrolling for hours and they found these like two crumbs that they said maybe that's a piece of an organism, maybe it's a contaminant, but yeah, it was tough. It was tough.
Absolutely. Yeah. The other questions were just a little bit more focused immunology wise about like ruling out XLP and CGD, both of which I responded that he actually had a whole genome sequencing that was completely negative.
Yes.
Even our pesky VUSs, really nothing to
It
give us
was
indication.
yeah. Yeah, it was reanalyzed. He had, I think, mitochondrial, like, yeah, his genome was reanalyzed. It was quite a deep dive. I think everybody was surprised that his sequencing was negative. I think we were wondering, even if this was an infection that we weren't able to pick up, he must have some sort of abnormality in his immune system or some granule failure in his granule mediated toxicity. There must be something that's predisposing him to the HLH, but um, Yeah, nothing. And I did see this question too. A good question about the ascites or pleural effusions. No, he did not have any
Okay,
ascites or pleural effusions.
great.
That would have been a great, easier sample for us to get, of course. Yeah.
I did want to mention that there was a paper from about 15 years ago in the Annals of Hematology that looked at using soluble IL-2 receptor and ferritin as biomarkers for lymphoma-associated HLH.
Yes.
And
Yes.
he in September when we
Hmm.
first got soluble IL-2 receptor and ferritin basically at the same time, he did meet criteria. Both they basically say a soluble IL-2 receptor greater than 5,000 and the soluble IL-2 to ferritin ratio greater than 2 both have pretty high positive predictive values, and combined, if both are positive, is a positive predictive value of greater than 95%. So he did meet those criteria. We don't, we see malignancy associated HLH so infrequently in
Yeah.
oncology. It's like 8 to 10% of the overall HLH, and we just don't have a lot of that's not something that we use. And even if it were,
Yeah.
and we saw that he was very likely to have lymphoma-associated HLH again, I think it was an issue of just not being able to get the tissue.
Yeah.
So it's so lucky that we were ultimately able to make this diagnosis.
I do remember we were trying to make those calculations too. Was he sort of just barely positive from what I recall, or was he very positive?
He was pretty positive, depending.
Okay. Yeah.
It really depends also on like when you looked. Like when he first
Right.
came in August, he wasn't, by the time of mid-September, he certainly like had values that put
Yeah.
him far over the threshold that they set.
Yeah. Yeah.
I don't see any more questions in the chat. I guess we could, I don't know if anyone has any last minute thoughts. I'm just saying, do you think JAK inhibitors should be postponed in secondary HLH till a primary cause is identified? I mean, I guess that's a tricky question, because
Yeah.
it, I guess, depends on the clinical status. And if you have to really control that inflammation, then you have to go for it. And, sort of ABCs of HLH, I guess. Yeah.
I think th this case was probably more so the an exception than a rule. I think it's probably not in every case that your JAK inhibitor may potentially treat your lymphoma. And I don't have concrete evidence that that is what happened. It was sort of just my suspicion, but I think obviously would defer to the oncologist, but I don't think that that would be a concern in most cases. And certainly as rheumatologists, we love our JAK inhibitors when patients need them. When their HLH is severe, they're unstable. It's a good go-to medication, but I think keeping that sort of suspicion open is what we've learned from this case. And if you can, if steroids need to be weaned, those can be weaned, and making sure that teams stay engaged. If your question isn't answered, teams, it may be easy to sort of have teams just sign off, but make sure that you're re-engaging teams.
Yeah, I mean, I think that the ruxolitinib could have like kept him well enough that we were able to ultimately make a diagnosis because he was very, very sick. And I think, as you alluded to, in patients who have JAK2 amplification and Hodgkin's lymphoma, there is some evidence that ruxolitinib can be, as a single agent, can be efficacious. And then in other patients where phospho-STAT 3 is positive, like in peripheral T-cell lymphoma, there has been some evidence that ruxolitinib can work. Really, you have to have evidence that JAK-STAT pathway is activated. And I think I didn't get to talk to our pathologist about the degree to which his was. Like, what does it meet the greater than 30% threshold that was used in this phase 2 trial? I'm not sure. But I think he needed the ruxolitinib, and it probably, controlled his disease long enough for us to get an answer.
Perfect. Yeah, I don't see anything else. I think there was some questions about EBV, but his EBV status was negative. Correct, Sonia. There wasn't any concerns for EBV like positivity at any point in his disease. So that didn't, at least didn't have that complicating factor. Um, but yeah, great questions overall. Um, Perfect. I mean, I guess that's it. Thank you everyone for joining. Thank you, Sonia and Dana, for being here. We such an interesting case, and I think a lot of learning points for everyone. Um, but yeah, I guess I'll give you the rest of your night back. Thank you all for joining.
Thanks for having us.
Bye.